Okay, I think we can go ahead and get started. I'm sure we'll have a couple more folks trickle in. Good afternoon. Thank you for being here. My name is Ashley Wallace, and I am from Kansas Department of Health and Environment. I am honored to introduce your speaker, Tori M. Gleason. Tori M. Gleason is a clinical analyst at a community hospital in Lawrence, Kansas. She earned her Doctor of Chiropractic degree from Palmer College in 2006 and a Master of Public Health in Epidemiology from the University of Kansas School of Medicine in 2023. With 19 years of experience as a sports chiropractor serving both rural and urban communities, and a decade of service on the board of a critical access hospital with a rural health clinic, Tori brings a unique blend of clinical insight and strategic leadership to her work. Her commitment to advancing health equity is reflected in her research on sexual and gender minority, or SGM, health outcomes. Tori integrates clinical expertise with data-driven approaches to improve population health, emphasizing inclusive and impactful communication. Her involvement on national and regional community advisory boards has deepened her dedication to centering individuals with lived experience in healthcare decision-making. With that, let's welcome Tori Gleason.
All right, who all's tired after lunch and after a long set? Okay, good. The chiropractor in me is gonna make you stand up. Everyone stand up. We're gonna move, do a little stretching, move a little bit. Let's get everything going. Has everyone enjoyed today? Yes. Have you taken some stuff that you're gonna take home tomorrow that you're going to use? So you're gonna deploy things, not just, I got a day off of work for a conference that I met my friends for coffee. It was awesome. Okay, but that's kind of the nice thing about networking we missed during COVID when we couldn't have those opportunities. Keep stretching, keep moving. You're stop moving, keep moving. So remember, sitting is the new smoking. Stand up, okay? I won't make you stand the entire time, but we are going to make you move a little bit. All right, when you're ready, you can go ahead and sit down. So you can take the chiropractor out of the clinic, but that's kind of how that goes. All right, so disclosure. Liz is back there stretching, by the way. Everybody wave at Liz. So I was a content reviewer for Center of Daring through her 988 curriculum. And so anyway, one homework, and you're going to have homework with me, by the way. So sorry, afternoon teacher, you're going to have homework. Your assignment for this afternoon, if you haven't met her already, to meet her. Because this is about how do you engage with, that underserved population, people that need to have a seat at the table. Liz is a connector. She's a maven. She's somebody that you need to know because she knows somebody who knows somebody. And Liz and I, and we're all friends all over the state. And you're going to find that the population that we're serving or we take care of, we're very connected, and this is a very small state when it comes to this. So what are we here today for, right? And I guess I want to kind of hit on some of the themes that we talked about this day, right? It was data. We talked about partnerships and relationships. And what about data? And we're going to hit on some of that too, which I always love when my themes actually hit on every other speaker's themes too. You're like, oh, I nailed it. That's good. And so they talked about accuracy and collection. We learned that from the Blue Cross Blue Shield section, right? They couldn't even get the demographic data. Not good unless you're practicing. That's the other thing. You're going to hear from me about why it's so important for us to do continuing education and not just that, okay, you onboarded 12 years ago, you got the one session and you never have another one again. The kind of work that we do dealing with community partnerships, it's a perishable skill set. How many in here is community health workers or patient navigators? Anybody work in patient care delivery? Okay. What's the rest of you? You can talk back, I promise. I will not bite, it's too far. Okay, which one? Oh, go Holton. Okay, what about the rest of you?
We're in managed care at Cape.
Okay, very nice. Consulting. Okay, and so, some of this stuff is about, the different stories and that misalignment between the data, the partnerships. And when they talked about partnerships in terms of internal and external, right? That's the same stuff you're going to have when you're trying to engage with people in the community. This is about building bridges, about how to connect with groups outside of your community, but also you've got to get alignment with your senior leadership team, your C-suite, That's sometimes hard from a top down. I'm lucky enough to work for an organization that actually is championed by our SLT, and so I'm really proud of that. And then from external, how do we get that collaboration? Also, one of the things I loved is the trauma-informed care piece. You're going to hear that talked about in my talk as well. And again, after all of that, pilot something, plan something, innovate something, experiment, do something, right? I don't want you to storm and form for 3 years and it's been in the drawing board, but you never launched the plan, right? Oh, we know we've got disparity. Okay, if you know it, try something. And so that's where I want you to do is try something. Also, let's try and reduce harm too. Let's mention that before I say try something. So here's the stats. 2023, there was a published study. There's 129,800 LGBT people in Kansas. That's the city of Topeka. So you're like, oh, we don't take care of that many. You do, right? And if you aren't aware, then they're not telling you. And if they're not telling you, right, data is a collection, but it's the interpretation you have from that. Why aren't they telling you? What barriers do we have of them telling? Maybe it's a data collection piece. Maybe there's nowhere for them to put on there. Maybe it's an agency piece. They don't feel safe enough to tell you, right? Those are the kind of things we work with staff education, all hospitals, all healthcare, whether you're in an MCO, you're at the state level, you have those same kind of conversations on what you need to do. With this, here's your quiz. What percentage of LGBT adults are living in poverty? What do you think? C. The answer is always C, right? Stands for commencement. 22%. And back on that, over 2 million LGBT individuals use SNAP benefits in a year. 15% of LGBT individuals will use SNAP benefits compared to 11% of the gen pop that's not sexual and gender minorities. And as we're aware, there's some things happening in our environment that, SNAP benefits is a bit of a concern. So making sure that when we're talking about SNAP, we're aware of the underserved population that needs to be kind of engaged. All right. D is on there for a reason, Liz, in case you're wondering. I'm just letting you know. Which of the following is documented contributor to health disparities among LGBTQIA population among peer-reviewed literature? Which one? B it is. And I put increased access to culturally competent care. There's no such thing as culturally competent care, right? It's that cultural humility. That's where we drive from a perspective of. And I hate how literature still uses culturally competent as the framing they did, so that was on purpose. Got to make sure I tell the teacher back there, if you know the rule, you can break the rule. That's what I was told in elementary school. What is one evidence-based strategy for creating affirming healthcare environments for LGBTQI individuals? We talked about this in an earlier session. What do you got on this one? Yes, the answer is C. Displaying inclusive signage and offering staff training. C stands for commencement. So the idea is that we know we have to educate. One of the things I loved is they talked about a welcoming culture. That was the language that was in there. That's not any different than inclusive and affirming. That's not any different than a welcoming culture. They talked about education. It was creating that customer service, trauma-informed care, right? That intake process. We talk about this in here, the data collection. It's always nice when these sessions start to overlap with one another because we talk about Press Ganey, patient experience, right? I know everyone's like, ugh. But at the same time, isn't that what that's all about? Patient experience is about a welcoming culture, about removing those barriers, making sure it's a friendly and a safe place, an engaging space. And again, how do we build trust with those healthcare providers, those frontline workers? How do we, with our MCOs, with our commercial carriers, how do we build those relationships? I work on the pop health side of things, and how do we build those relationships with the 17,000, 20,000 members that we might take care of? And increasing that respect and safety. And again, it's creating that welcoming culture. It's that safe space you have for whether your waiting rooms and that inclusive non-discrimination policy posted, post it. Because when I go into a waiting room, I am looking for signs that I am welcome there. You're not going to tell me that, but I'm going to look for it. And if I don't, I'm going to vote with my feet. I won't come back. And your patients are doing that too. So what do we know from a data perspective? We know that LGBTQIA individuals have higher incidence of heart disease. We have higher smoking rates. We have higher increases in experiences of stress, intimate partner violence, especially with bisexual individuals, lesbian individuals. Intimate partner violence is extremely high. So in your SDOH prepare screens, be mindful of that as you're screening individuals. Be looking for that. And if you can't, you need to disaggregate your data as well. On the inpatient side, we do a really good job with our SDOH screens because it's required, right? It's not required on the ambulatory primary care side yet. We'll get there eventually when they require it. That's kind of how healthcare works. So behavioral health, that's another issue where we see a higher incidence with that than the Gen Pop. Substance use, obesity, as I'm experiencing that here because of stress. We learned about that in the other room. And then disordered eating. Disordered eating is a large experience, and we talked about lived experience. Disordered eating with the LGBTQI, or you'll hear me say the SGM, the sex and gender minority community. And so be aware of that disordered eating is a big part of it as well. And then breast and cervical cancer. So when we talk about our BCS or our CCS rates, when we're trying to meet those metrics, right, understand they're not going in for mammograms. They're not going in for PAPs. Well, why is that? Historical harm, trauma-informed care, right? That's why we need to make sure we're educating our staff. You'll hear about an initiative that I helped Menorah Medical Center with on their mammogram screening rates and trying to actually reach out to an underserved population here. I'm going to have a neck issue by the time this thing's over with. And I can't stand in front of the speakers or it'll squawk at you. So, and again, it's just a little thing, just inclusive language on your intake forms, right? Welcoming language. And if you don't know how to do it, ask somebody. There are plenty of people in this state that can actually help you with that. Just avoid those assumptions. And, you know, they talked about earlier that, you know, unknown, unknown, unknown as they were filling out information from a documentation standpoint. Well, to see is to know, and I don't want to guess about your health care. Don't put unknown. Ask the individual. And if you're afraid to ask, which clinics have, because they're afraid maybe they've been yelled at in Western Kansas. I grew up there. I know what that's like. Trust me. Wasn't fun. There's training. One thing that I would recommend is the National LGBTQIA Health Education. It's associated with Fenway Health. It's a FQHC in Boston. They've got great free education, free training, pre-pamphlets, pre-videos on. They'll show you a video how to do it wrong, and then they'll show you the video on how to do it right. It's free. And so, and you're gonna get my cell phone and you'll get my email at the end. I can send you any link that you need afterwards. Accountability, right? That's what we face. Again, I talked about that onboarding experience. It's that one training you got as you onboarded with your organization years ago. This needs to be an annual training, health equity training. And it needs to be, where does the accountability piece? Well, if you don't do your annual training by October 31st, you don't come to work. You shut off email access. You don't get to go to work, right? That from an accountability piece, that has to be the level of, from a health equity standpoint is, if we want our providers to engage, if you want your team to engage, you've got to actually have some buy-in to say, this is so important that it's a requirement for us to work here from a health outcome standpoint. As I click through everything here. Sure did, didn't it? I'm going to reach out for help here. Is this not clicking through anything yet?
I can see you clicking through on that.
So what do you do with your organizations when it comes to education? What do you require? From a health equity standpoint, do you require any annual education? Show your hands. Okay, good. And it is annual, correct? Okay. Does it also involve underserved populations? People of color, LGBTQ, love it. That's really important. Was that a hard shift, or has it always been like that at your organization? I think that's true for all of it, right? I mean, it's always an area that we can improve from. The education piece is hard, especially, they talked about a scarcity mindset, right? We don't have enough time, we can't get provider buy-in, we can't get nurses to buy in because they're busy bedside. We always have things to do, right? But if we took that abundance mindset that they talked about in there and just like, no, it's so important that we actually carve out time for that, because we know that it's tied to better outcomes. We know we can decrease stress. We know we can decrease stigma. If we took that abundance mindset, I think it would be different. It's just a paradigm shift is all it really is at the end of the day. Ooh, we're back. Sure. Okay, perfect. I'm going to back up just a little bit. Okay. So just involve SOGI on your forms, your sexual orientation, gender identity, right? And ask those questions. Ask an admin sex, right? Ask your the sex portion, the gender identity portion. Ask those questions on your intake forms, and even your EHRs. It's funny, KU Cancer Center did not have the SOGI portion turned on in their electronic health record for the longest time, right? Even in Epic. And we all talk about Epic being that pinnacle of like, everyone wants Epic, and even us being Oracle, I would love to have Epic. Go ahead.
Can we also not conflate sex and gender on the intake forms? Can you speak on that for a moment?
What's that?
Not conflating sex and
Oh, absolutely. And so because, sex and gender not being the same thing, right? And so some Oracle Cerner, we have, whether it be biological sex, every vendor has a different thing. Some is biological sex, some is sex assigned at birth. Every vendor will be a different thing, but making sure that the gender is not, and some EHRs actually list it as gender. The good thing is that's going to be a required field, especially with our EHRs, and it's kind of a nice thing we have going forward. And being able to disaggregate that data. As we run all of our SDOH data for our inpatient, again, we're looking at admin sex, right? Sex, gender identity, we're looking at sexual orientation. Those are all different things that we can then look at what are our outcomes for positive screens with the Prepare screen based on those, and being able to say, okay, are we noticing a trend here with our, maybe it's housing insecurity, maybe it's food insecurity, whatever that might be in your organization, but making sure that you're asking those questions. And Liz is right. Go ahead. Great question. Intersex, and then A is oftentimes asexual, is one of the things that we talk about. And so this is something that Liz speaks on a lot and is a champion for. I know we keep adding letters, and it's hard, right? And thank you for asking that question. And it's one of those things that we do that for inclusion. We add the plus at the end to make sure that we know that there's other identities in there within that are also representative. But you'll see me, my 46-year-old self that has a lot of unlearning to do, will still use LGBT. So if you hear me, it's me still trying to learn. And here's the other thing I want to tell you. I make mistakes. I'm in the community. I take more than one letter. I'm very greedy. And if I'm going to take more than one letter, you'll understand it's okay to ask those tough questions. It's okay to ask your staff to that's from an intersectionality standpoint, right? I'm not just trans, I'm not just this, I'm also a parent. The most boring part of me, personally, is the LGBTQ status. I will talk to your ear off about me parenting, or my time as a chiropractor, or my time in health equity, right? All those intersectionalities. I am also very privileged too. For one, I'm facing this way, not this way. I realize the letters I have behind my name makes me privileged. I realize the amount of melanin I have in my skin makes me privileged. I'm privileged. And so because of that, I also make mistakes too. And if you see it, call me on it. And call me into a conversation. I still have a lot to unlearn and learn, and I will always own my stuff. So I want to make sure that you all know that. So regular training. And then those feedback loops, right? When we make a mistake, have a place where we have psychological safety. I know we talk about that from a hospital standpoint, but a place where people could say, you know what, I really didn't like how you used that acronym, right? You forgot some letters. Great. Let's have a conversation. Let's engage. Or maybe it's patient care. Our patients need to be able to hopefully feel safe enough that they could tell us. Do we have a community advisory board or a PFAC, a patient family advisory council, where they can actually say, hey, we're hearing this in the neighborhood that it's not a very safe place for care. Having those type of external facing organizations and committees are really important to actually engage from a health equity standpoint. You're going to hear me say trauma-informed care a lot. There's a lot of trauma in sex and gender minority communities. I hate going to my primary care provider, and I'm in healthcare. And I have to go in for my mammogram every single year, just like a lot of people do. And I hate it because I've had awful experiences. And I'm going to overshare, so you're going to learn a lot about me today. You're going to probably learn too much about me. So I can remember going into one place, and it was awesome. It was my first one. So I'm like, yeah, I got this. It's going to be good. It was not so good. And they're like, so the tech, she asked me, she's like, what are you transitioning into? And I'm like, that's awesome. And so, a female, I said? And she's like, okay. So I get back the RAD report from the radiologist, and it's like, patient, male, transitioning into female. And it was just verbatim the language that she put in there. And it was just such a horrible experience. I didn't go back for my mammogram the next year, right? And if it's that type of things, like words matter. Culturally, from a trauma-informed care, intersectional care standpoint, the words you say to your clients, your members, your patients, your practice members, that matters. And now I've had my BRCA 1 and 2 checked. I've had all that. I get to still go in yearly. That's awesome. I just had that here a few weeks ago. We're still good. But again, we're a population that delays care, needed care. And so we have trouble meeting our breast cancer, our colorectal screening cancer, our cervical cancer screening rates. And it's because of harm. Bisexual women are a notorious population for not going in for PAPs. And we know that population has to be taken care of. So what are we doing to actually outreach with them? Because we see those from our, working in pop health, working with our population. What are we doing to outreach to those communities to make sure that they get in to get screened and get checked? Are we doing anything special for them? If we have the data, right? If we theoretically have the data, we should be able to outreach to them. And what does that look like? Are we bringing them to us for us to tell them what they need to do? Or are we going to them to where they're at in the community? Map the gaps. This is something as a clinical analyst, I'm always looking for the holes. I'm always looking for the gaps. I want to know where the underserved are, where the individuals are that are not getting taken care of, who we're missing. And often from a numerator denominator standpoint, right, we're always chasing that numerator. But it's really who's not there, who doesn't show up, right? Those are the ones that haven't been in 5 years. Sometimes when we look back, we're only doing a 3-year look back. Well, what about the 5-year look back or the 7-year look back? The people that haven't been in 7 years that should have been in for annual checks. Those are the ones that we need to make sure. Sometimes our inclusion, from a data standpoint, sometimes we set the perimeters so tight, we're going to miss population. So we have to be careful. And I talk about digging deeper when it comes to data. We talked about that 2018 through 2024 when they looked at their data in Blue Cross Blue Shield, right? Why is it 2018? Why not 2011, right? 2010? Who hasn't been in that should have qualified based on our preventative guidelines and a task force that should have been in for care? So the populations that are often overlooked, right? It's our LGBT population that's rural, right? It's easy. How do we engage with them to actually have populations? And again, this is about bridging the gap. How do we connect with them from your organization? If you're a group that's trying to connect with, hey, we want to take care of and we want to screen our LGBTQ population, we want to increase that from a mammogram screening rate. How are we going to get those individuals? Instead of at the last minute asking them to say, hey, can you tell your friends, why don't you engage with them early and say, we'd love to invite you in because here's what we'd like to do. We'd like to actually help you out. Or better yet, What do you observe in your population that's from a health equity standpoint that's missing? Before you tell them the answers, why don't you ask them what they need? Right, one of the phrases that I like that they used in that other one is lean on the neighbor voice. That really resonated with me. But that's what that is. It's not us being the experts on their healthcare, right? If we're truly person-centered healthcare and person-centered and patient-centered outcomes, then maybe we should ask them what's important to them. We should lean on that neighbor's voice or that patient voice. Again, SOGI data, you're going to see that a lot with me. Training on the why and how to use it, right? And I'll say this all the time, if we don't ask, we can't see, and if we can't see, we can't serve. And that's the important thing. That's why data collection and why, as a clinical analyst in data analytics and pop health is really important to me. We have to ask those questions. And that's why connecting with our CSSs up front, our medical assistants as they room a patient, our MDs, DOs, our NPs and PAs, that's why it's really important to engage with them. It's really important to ask because we can take care of them better. And again, who doesn't have a seat at the table, right? It's collaborating with individuals from the community. How do we connect with those organizations that are already doing the work around the state, in your city, around the, maybe it's regionally, maybe it's across the country. How can we connect with them? I'm a huge champion for community health workers, peer navigators, patient navigators, whether they're embedded or whether they're out in the community itself and not within like a CSL service line or cardiovascular service line, if you will, or pediatric service line. But it's important to train and outreach. And again, we're going to come back to it. It's a perishable skill set. We've got to do this yearly. We can't just train you one time on how do you engage with, because again, the other thing we talked about was it was about partnerships and a relationship. If I invited you in, or let's say you're doing a mammogram screening and you're like, Tori, we'd like to invite you in about our mammogram program. And then after you ran the program because you got an award for it, and then you never returned phone calls and never emailed me ever again, I'm going to feel like that's not much of a relationship. I'm going to feel like maybe you kind of used me to use my knowledge and skill set. And if that's what it is what it is. But I want to engage, as do other people in the community, on decreasing that stigma. Is like, you really care about my voice. You care about my subject matter expertise, right? How do we go where the people are? In healthcare, we have a tendency of, at the auditorium, we want to invite you in for an education event. Come to us. Always come to us. We don't go to you. But it shouldn't be that way. We should be in their meetings. We should be partnering with them. We should have, from that scarcity mindset, there's not enough time, there's not enough money, there's not enough people. But what if you're like, you know what? You've got a LGBTQ coalition in town, and we're going to make sure that somebody's always there. We don't need anything, but we want to hear from you. We want to engage with you. We want to build that relationship with you so that when we hear things that we might be able to help you with, or that we want to partner with you, or you want to partner with us on, we can use our resources from that standpoint. And the virtual town hall, you'll hear about Kansas Leadership Center. They did one as well, and listening sessions during COVID. Right? That centered lived experiences. Storytelling is everything. The stories tell us why. And understanding that, like, I love, as much time as I spend time in quant data, my passion is in qual. I want to hear your stories. And it's that photo stories, right? It's the picture. You remember that more than you're going to remember the answers always see, right? You're not going to remember 22%, but you're going to remember that Tori had a horrible experience with her first mammogram, because that's patient-centered care. It's the stories that you remember. And when you're taking care of your clients, your members, your patients, that's what you're going to take with you. So we need more stories, collect stories, not just your quant data. Connect and get your qual data as well. Collect those stories, tell those stories, get those permissions. As they had earlier, have them tell their stories if they feel safe enough to do so and it's a safe environment. Right? Align on those health equity outcomes. Again, we come back to, have you had your breast cancer screening, your colorectal, your cervix? Do you have a primary care physician that you normally see, right? All those things that really matter from us from an access and barriers to care. We know that LGBTQ patients do not go in for routine primary care. Many don't even have a primary care provider. So they use urgent care, they use ED, and they wait till it's delayed care before they even get care in the first place. So your initiatives where you're like, you know what, our initiatives is going to be, we're going to make sure that we're going to make, we're going to make sure that everyone has a primary care provider. Are you doing any outreach to those disparate populations that really need that, right? Ooh, we're going to pay attention to that LGBT population to make sure that what are their barriers to having one? Are there barriers? And understanding those in that conversation is important as well. Also at 46, my neck doesn't turn that way, so I got to go over here. So even chiropractors fall apart. This is the big one. I love attending other people's meetings, right? That strong relationships lead to stronger programs and fewer misunderstandings. And that, learn from each other on your missions and challenges and strengths. Understanding that what do you do in your organization as a consultant? But maybe in the organization I do, you're like, hey, we have congruence. We got some stuff that might align with you. And if you're attending meetings, we have a Wichita LGBT Health Coalition. I don't know, who knew we had a Wichita LGBT Health Coalition? Did you know that you could participate that online? And you can participate in the meetings, and it doesn't cost you anything? And you can learn about things that are going on, and even though it says Wichita in the name, it's statewide. And so there's an organization right there that when you're doing something, you can partner with the people. We have 150 members or so of that group. So partnering with groups like that and just attending you know how it is. We all do it. We're working on something else while we're watching a Zoom at the same time. But you're there, right? You're listening, you're engaging. If you see something that kind of perks your interest, that's something you can engage in. Those are the things that I would say, moving from a scarcity to an abundance mindset, we're going to assign one person on our team. We'll make sure that one person in our organization always attends that meeting. Didn't cost you anything, right? Maybe they ate their lunch at the same time and they had their camera off. Or maybe they have their camera on, you've got your organization in there, and people in that room know that you are engaged with them. You're starting to build that relationship with them. So that when you have that next event that you're going to have, they're like, hey, I recognize you. You show up. And the people that show up are the ones that kind of provide that level of safety, if you will. So here's what I love. Co-writing grants. Oftentimes, those patients those communities don't have grant writing capabilities. They got great ideas, but they don't have the skill set. You have grant writers, don't you? You have grant writers. What if you partnered with those organizations to say, you know what? You got a great project right there. We'd love to partner with you. We've talked about partnerships, external. And I think there's some congruence there. We're going to use our capacity, we're going to use our capital, right, to write this grant with you, for you, and take care of your community, because that takes care of you all, which also takes care of us. There's opportunity for that. Is that how do we share data for joint initiatives? I know that we silo our data. And that is a really hard thing that I have not figured out yet. I don't have much to say other than I haven't figured it out yet. So, because it's like, well, they're just right across the street, And so, literally, Lawrence Douglas County Public Health is right across the street. But I also understand that it's hard, and we do the best we can, and so do they, and it's just hard. And we haven't figured that out, that entangled mess of data collaboration yet. And I think it's because these systems don't talk to each other, right? And it's not a data agnostic type of collection that's, de-identified data, if you will. And so it gets to be challenging at times. So how do you involve partners with the programming from the start? Again, I mentioned that. There's nothing worse than us coming to you for an initiative, and you're like, man, we got everything done. We just need to find the one trans person that's going to say, we did this for the community. Will you be that piece of person for us? I've been asked for that role. It's fantastic. And then you're like, well, what about this? You're like, well, that wasn't part of the program. And you're like, man, did you consider this? No, we'll consider that next year. And so involve individuals from the start, right? They should be part of that planning. And if you truly value it as their subject matter expertise, or let's just say their lived experience, right? Then involve them in the planning early. Engage them early. Not at the tail end to say, on your little Gantt chart, you're like, oh, crap, we got to find the legitimate AQUA person at the end to check that on. And you're like, we are a health equity organization. Got the badge. So how do we measure impact and celebrate wins, right? Track those outcomes that matter to both partners, right? If it matters to my coalition and it matters to your organization, then let's champion those together. And then actually say, we worked on this together. It was a joint collaboration. Oftentimes you'll see healthcare facilities that they want to take the ownership of like, we did this. And I'm like, yeah, but it was kind of a team win. And so let's make sure that we share in the team win together. And so making sure that we're not stealing that limelight, if you will, from those partners that actually participated in it and naming those. Okay, here we go. So what are some examples of ones in Kansas? Liz, who had to head out of the room, 988 training, Center of Daring. She actually hired people to write content that was on LGBTQ for the 988 training statewide. And so she hired subject matter expertise, the PhDs, licensed clinical social workers. She had a whole laundry list. And then, again, in my disclosure statement, I was one of the folks that got to review the content that was created, and then that content was then rolled out. One thing that she did that was different, she paid everybody that was involved. If you created content, if you reviewed content, you were compensated for your expertise. Too often when we have initiatives, right, we're on salary. You know, I'm here on, I didn't take PTO, but I'm actually on the clock right now, right? I'm being paid to be here right now. Thank you, LMH. And so, but how often do we bring people in to volunteer their time, to give their time? When you're talking about your budget process, build compensation into that. $100, $1,000. What is it? I don't know. I know it's really easy to slip into scarcity. Like, well, I was with you when you said a Starbucks gift card. But when you said $100, that was way too much. Think about how you might build that into your budgets. Because again, if you truly value their experience because they're actually enriching your program, your outcomes, then compensate them for their expertise, right? Again, the LGBT Wichita Coalition is associated with the center in Wichita. But again, the people that run it are amazing friends of mine. They're nurse practitioners at KU Midtown, lovely human beings. And another great friend of mine, Amanda, she has M-Care Healthcare. She's got a food pantry and clothing closet. Right, those are the kind of groups that you can partner with. You know, Amanda's got 2,000 patients in her practice as a nurse practitioner, a large clinic, right? You look at KU Midtown, a massive clinic there that takes care of a lot of people. Partner with those organizations because they also have people that work there that have a lot of expertise and that could really help you engage. University of Kansas Health System and their LGBTQ patient-centered care clinics, phenomenal. I'm a patient of those clinics, right? And so they've done an excellent job of experimenting, piloting, planning, failing at times, but also, more importantly, receiving feedback and saying, you know what, you're right, I'm sorry, we're gonna do better. And they go back and they experiment, to use Kansas Leadership Center language, right? They experiment, they try something, they do it again, and they launch it, and it's better, right? I would rather you launch something that's not perfect than not launch, you know, then it just stays in the hangar. Launch something, do something, experiment, innovate, try something, but also have that feedback cycle to where you can get information coming from individuals. Here's the plan that I was involved in, the breast and chest cancer screening for transgender and non-binary individuals. And so, it was a whole day. They had their primary care, they had their medical doctor was there. They had their entire team. All the team had training on it. I will tell you, it was actually a really good experience. I came as a patient because I'm like, well, not only am I going to be consulting you on this, and again, I volunteered my time, but I also went through it as a patient, and then I gave them feedback at the end, and they all wanted to hear, what did we do right? What did we do wrong and need to improve? And they all listened. It was a fantastic way of like, you know, if you'd have a better, and one of the things I provided to them is, if you'd have your primary care physicians actually referring patients to this, instead of throwing something up on Facebook, right, and just hoping people are still on Facebook, and actually see the ad to actually come in, right? Getting that direct referral source, if you will. And they're like, we didn't think of that, right? Those little things like that, how can we drive upstream to downstream for services like this? And again, that was at Menorah Medical Center, and they did an excellent job there in Overland Park. Kansas Leadership Center and Ed O'Malley, when he was the director there, had town halls to LGBTQ individuals. It was a fantastic engagement and opportunity because they realized that it's an important part of what KLC is missing, what the Kansas Health Foundation is aware of. They talk about systemic racism with Kansas Health Foundation, and that's a part of, I don't know if you've gotten their new book, it's free. Get that book requested. It's kind of a nice little thing to have a conversation about. So let's get into action. What can you do tomorrow? And I'm actually going to engage with you. I know we're at 2:52 here, but think about one change you can make in the space to be more affirming. What is one thing you can do on Monday? Or actually have a conversation with? Here's your action steps, your homework. Great thing is there's no wrong answers. Just share what you think off the top of your head. You're like, man, if we could do this one thing, what would it be Monday that you could work on? Absolutely. It doesn't require you to go to the board to ask for permission, right? It's really the low barrier thing to do is just get involved, right? And if you have a local one, if you're in Hutch, they've got one. Garden has one, right? Johnson County has one. Gardner has one. There's several local ones, but it's an easy one because they've eliminated the barriers of if you just hop on a Zoom once a month. That would be an easy one right there of like, I'm just going to listen to ideas. I'm going to hear from the community. And not everybody that goes are even in the community. Most of the people that go are just caring people that just want to do a better job of taking care of them, which is what I really like because I'm still more than one letter. Think about training that you can make available to your team. What are your gaps? It's hard because it involves a lot of decision makers.
It's funny because we were just doing thinking about annual compliance training, and we scaled back the training that was explicitly related to LGBTQ and things like that as to, maybe not offend people. And so that bothers me a little bit that it's like, we need that training because we don't live just inside our bubble. We work with outside organizations and stuff. So I think that, really being afraid to offend some people, afraid to use words that might have a detrimental impact on funding and things like that. So I think that is a gap in training, is just what can we train on and not make the wrong people mad and not lose funding.
It's hard to kind of thread the needle on that. Mm-hmm. And when you make it about patient-centered care, it's easy, right? I know that we do this game of semantics too. Make it patient-centered, about lived experience. And if you make it about lived experience, it covers a whole lot of things, right? And you don't have to call it the sex and gender minority module, right? But we had the lived experience module, which interestingly enough, the slides were the same. But it was our lived experience modules. I know it's a game. We all know it's a game. And I get it too. And it's hard. I want to speak to that also, that fear of offending. Because I think that's why a lot of organizations are afraid to do it. Mm-hmm. We said the wrong things. How many of you are in direct patient care and you ever said the wrong thing to a patient and it did not go well? Oh, yeah. Did you quit healthcare after that? Did you like, man, I'm never going in that clinic suite ever again? What'd you do different the next time?
Ask questions, how I can do better. Learn, be respectful, just be a human. Hey, I made a mistake.
That sounds like
Just acknowledging it.
Evidence-based practice to me. If I'm your patient and you make a mistake, yeah, you're like,
Thank you for telling me.
dang, that sucked. Sorry. Tell me what I can do. Now, some individuals don't want to do that labor. They don't want to educate you. There is that barrier. But some will say, thank you for asking. Here's how I'd like to be addressed. Here's how I'd like to do that. And again, it's the unlearning we have to do. And again, as a member of the club, I still make mistakes. So stop holding yourself to an impossible standard that you're not going to make mistakes. If the people that represent the letters in that alphabet group, right, that I'm a member of, are going to make mistakes too. So just do the thing. And then when you mess up, because you will, apologize, but don't do this. I'm so sorry, I'm so sorry, I'm so sorry, I'm so sorry. You're like, God dang, I feel really small right now. And so just, I'm sorry. You know, I'll give the experience. I was going in for a therapy appointment, and I misgendered my therapist. That was awesome. Like, God. I'm like, I said, I assume she, her. She's like, nope, they, them. And I'm like, crap. So I make mistakes too. So stop holding yourself to that impossible standard. Be kind to yourself. Show yourself some space for grace, right? You're in healthcare. It's not easy. It's hard work, right? You're not robots. You're connecting with humans. Again, we talk about patient experience. We talked about patient-centered care, person first, right? Part of that is you're making mistakes, but just like in relationships and friendships, when you make mistakes with your friends, you make amends. You do the same thing with your patients or your clients, your members. I was a jerk. I'm sorry. I'm trying to do better, right? It's not hard. But you didn't leave the profession. You're like, never again. We ended the education altogether. We'll never have it again. We just hope we don't mess up. All right, think of one LGBTQIA organization in your area. Now, we know you don't get to pick the Wichita Health Coalition. We talked about that one. Name one. Good. Name another one.
Will you repeat what they say since it's being recorded?
Topeka Pride. Another one. Does anyone know another one? I know you're like, that's it, I got two. I got two. It's good, right? It's better than nothing. And it's hard, but also, right, when we're doing that adaptive work and we're talking about partnerships, shouldn't we know the partners in the state, in your local area, in your region? So maybe one of your homework assignments is, or on your car drive home, somebody get on phone that's not driving and Google LGBT coalitions in my local area or in the state of Kansas. Or maybe you've got that one trans friend that actually might know most of them, and you just say, hey, Tori, do you know of any of them? Right? Or something along those lines, right? Use your resources. It is an open book test. It is not something like, this is easy work. And it's hard work, but like easy in the sense that the resources are at your fingertips if you just ask and you just use them. So what could you learn if you actually attended the meetings? If you went to those, what would you learn?
What they care about.
Do you think there's ever a moment where what we care about and what they care about are two different things? Maybe I care about breast cancer screening and they care about food insecurity. And if we don't take care of those upstream barriers, it doesn't matter what my numerator says, I'm not going to be able to get that patient to preventative care. I'm like, ooh. What else might we learn from them?
I'm thinking from a small rural hospital perspective where I used to work. We had no way to identify and collect data. So I think it would be really valuable to learn, how can we, when you come to our facility, how do you want us to collect this data? What would make you most comfortable? How do you want us to approach this so we have that data and we can act on it? Because, you're a data nerd, you know that. If we don't have that data, we can't do anything with it. And so I think in a rural community, I can't think of a single LGBTQ organization in our community. And do I think anybody would tell us when they walked in, if we asked them SOGI questions, are they going to share those with us? I say us, I don't work there anymore, but my heart is still there. I don't think they would. And so I would really want to be able to learn from them, how do we approach you in this very little community that sometimes is very judgmental, and you come from a rural community,
Yep.
so you understand that. I think it'd be really valuable to learn, how do we get the data so that we can support you.
Involve them in your HIMSS conversations, your IT conversation. Do you have an IT committee? Right?
We have Cody.
Right? Our hymns, go ahead.
Well, and that's just where I was kind of where
Here,
Tammy
come on up.
was going.
Is how to help our staff in a rural community be comfortable with asking the questions, like the gender questions, because they are built into our EHR now, so they are there. I think they're optional. So, but and then you sparked another. I also lead our PFAC, and that's just not a population that's probably represented on our PFAC. So that's probably another homework assignment for myself too. So just a couple takeaways for me. So I appreciate that.
We have 14,500 trans folks in the state of Kansas. 14,500.
For me, if your staff aren't comfortable even asking the question, I'm not going to tell you. So I think that internal campaign is important. Yeah, I was just saying the folks that ask the question need to be comfortable having the conversation, because if they're not comfortable asking, somebody's not going to give you that information.
And that's where I talked about that one that was associated with Fenway Health. Role play, right? Let me be your patient. Try it on me and mess up, and that's okay. And then let's see what it looks like to be. The easy thing is, these are the questions that we ask our patients. Here's why. And feel free to answer any question you'd like to, and you just go from there. We have questions on, and again, the scripting is already there. You just have to follow it and practice it. And it's going to feel uncomfortable the first time. Remember, who's nurses in the room here? Remember your first time you go into lab and you're practicing your history and you felt like an idiot, right? You're going to feel really uncomfortable. You're going to feel awkward. The first time you did the practical examination and you're doing those write-offs and check-offs, you're like, man, I was so bad. Guess what? You're going to be bad the first time you do it. And that's okay, because anything worth doing, you're going to be terrible at. And just create that culture from an internal side of it's okay to be bad at this. But after we practice enough time, you're going to get better at it. And then it's going to become more comfortable. And then as you start to practice that, you're going to have those patients that are going to push back. They exist in every practice. But just because I have 10 people that are angry at me doesn't mean that it's going to keep me from asking those other people, because those are the ones we need. We need to make sure that the unheard, unseen, unserved actually have a place of agency where they can actually speak up, right? And I know that's hard, and changing the culture. And sometimes we have EHRs that actually has the SOGI module turned off. Turn it on. What do you have to lose, right? Are they going to stop going to your practice just because you asked for their sexual orientation? Guess what? Patient did not disclose. It's an option. And so they have that option to answer. But just because they don't want to, we have that option there so someone else can. And that's the important thing is that that's what inclusion looks like, right? We talked about that from a welcoming culture. A welcoming culture is that we don't just welcome the majority. We don't just welcome the people that, are the loudest. That would be an awful place to practice. We want to make sure that it's a welcoming culture for all. Disneyland doesn't just serve some people. They serve all people, right? And if we had that Disneyland kind of experience in healthcare and our service of making sure that people felt like it's the greatest experience of my life. I can't afford to go there, but it's the greatest experience of my life. And those are the things that we need to work on. And again, I want you to invite them in. That red chair, who's missing? Are they on your community advisory board? Do you have a community advisory board? Maybe you should start a community advisory board, right? And we didn't call it anything equity. It was a community advisory board. It is a CAB. So create a CAB, and you won't lose your funding. And if they have different lived experiences and intersectionality, great. Your organization just got better, because now they have a place where they can go and actually share their ideas. They can hopefully have a sense that you also create a welcoming culture in your CAB of these are our acknowledgments. These are our things that we're not going to cross that line and people feel safe here. Those are the type of conversations I want to encourage you. So if you could go join a health coalition, Wichita would be a good one, and start a CAB and start education, 3 for 3, you're in the Hall of Fame. If you're batting 300, you're an all-star. Try those things in the next 12 to 15 months. Your organization will continue to grow. right? And sometimes I know that I'm in a 2,000 FTE organization. It takes longer for those ideas to spread. So plant the seeds. And then just watch those bloom over time. Build that circle of influence and keep going from there. Questions? Yes.
Thank you. Maybe not a question, but perhaps a comment. Well, we can make it a question. So at LMH, I would assume, or I would think there's probably a welcoming culture with things as small or as simple as like a pride flag at reception or a sticker outside someone's cubicle, or if I see a nurse that has a lapel pin that I jive with, like that's going to make me feel more comfortable. For folks who are clinics, hospitals in rural areas who maybe haven't got on board yet, can you speak to those kind of what feel like? To me, it sounds like an easy change.
It is. A badge buddy, right? A little badge buddy. A safety pin on your lanyard, right? Little things like that, right? It's you're safe with me. An equal sign. Those are little things that the community looks for. You didn't say anything, but your badge buddy said everything. And sometimes that's all that needs to be said and shared, is to let me know through your nonverbals that I'm safe here. And again, you didn't throw a parade down the main street, right? But in your lanyard and your badge buddy, it told me all I needed to know, that I was safe with you. That in your clinic suite with my provider, with my PA, with whatever, that it was a safe place to be. I know we're over on time, but any other questions? Okay, you'll get these slides, but here's my cell phone number and my work email. Text me. I'm better at text than I am phone calls. Or if you want to email me, that's fine. But you also get me, right? I'll help you. Because you're going to mess up. And it's not as hard as you're making it out to be. It really isn't. Any other questions? Here you go.
Okay, same spiel as earlier